Hi, my name is Jeremy Jones. This presentation is a quick review of cardiac electrophysiology and the information that I believe is missing in a lot of nursing programs. At least certainly it was in my program. I wrote this review several years back and teach it from time to time, and those that have taken it found it useful, so I decided to record it in an effort to help more people that need a review. So let's dive in. As you likely remember, this is a normal flow of electricity about the myocardium. It's important to realize that in lead 2, as the signal moves from the right arm to the left leg, there's an upward inflection in the EKG tracing. And the opposite is also true. When the signal moves from the left leg to the right arm, then there's a downward inflection in the tracing. In a healthy heart, the pacemaker, which is where the electrical signal to initiate the heartbeat begins, starts here in the SA node. Looking at lead 2, as we will with the rest of the presentation, as electricity moves away from the SA node through the atria, also moving in the direction from the right arm to the left leg, there's an upward inflection in the ECG tracing known as the P wave. Then we get a slight pause in the AV junction, and then possibly, not always, but sometimes we get a Q wave, which is this electricity going back up towards the right arm, and then the positive inflection, or this upward inflection, that we call R wave, which is the electricity flowing from here down towards the apex of the heart, also down towards the left leg. Then as the electricity begins to move back up the outer walls of the ventricles, then you get this downward inflection in the S wave. And that was the normal, kind of the normal electrophysiology of a heart and what we expect to happen. But of course, there's different things that happen in the heart, and different dysrhythmias that we need to be able to identify. And so there's really a true process that you have to take to be right when you look at an EKG. If you look at an EKG and you do as I was taught in nursing school to match up the picture, it should kind of look like this. You're probably going to get it wrong about half the time. And here's the things that we're going to look for, and we're going to go through those step by step. So the first step in naming a dysrhythmia is deciding where the pacemaker is located. Where is the beat initiated? I think it's important to know, and you probably remember, that one of the unique properties of cardiac myocytes or heart muscle cells versus regular muscle cells is automaticity. And automaticity is the characteristic that allows any heart muscle cell to cause depolarization on its own. And then when it depolarizes, it causes a chain reaction of all of the adjacent cells to also depolarize, which kind of continues to move through the entire myocardium, or that part of the heart. So if that pacemaker fired in the atria, that it's going to depolarize the entire atria, and then that as long as the AV junction is normal, it'll collect that depolarization, pause for the QRS, or pause for the PR interval, and then propagate through the ventricles as it would normally. If it's in the ventricles, it's going to fire in the ventricles, and then only be contained in the ventricles. The electricity cannot move back into the atria without some sort of alternate conduction pathway that we're not going to discuss in this course. Anytime your SA node is your pacemaker, you're going to have these upright P waves as we discussed before, and this is the defining characteristic of a sinus rhythm. When the pacemaker is in the AV node, or AV junction, then we call this a junctional rhythm. The defining characteristic of a junctional rhythm is that the P wave is either upside down or non-existent with a narrow QRS complex. So if you take a look at the myocardium, the reason why this happens is because if the junction if it fires high enough in the junction, then it may cause some propagation of electricity back into the atria, causing going back up towards the right arm, causing a downward deflection in the EKG or an upside down P wave. But if it's far enough along through the junction, it's not going to fire backwards. It's going to come straight down through the bundle hiss and bundle branches, causing no P wave and just a narrow QRS complex. With a ventricular pace beat, we notice this is always larger than 3 small boxes. This QRS complex is always greater than 3 small boxes, and there's no P waves. There's just some myocyte located in the ventricle somewhere that, because the electricity is not following the normal conduction pathways, it goes through very inefficiently and just takes a lot longer to get through the heart. So you have these really slow, wide beats. Then you need to ask, what is the rate? We only have 3 different ways of describing speed of a rhythm. We call slow bradycardia. Normal is either stated in the name or it's just assumed, and faster than normal is called accelerated, and fast is known as tachycardia. These speeds are attributed based on the intrinsic rate of the pacemaker's region in most cases. Each pacemaker region of the heart has its own intrinsic rate. These rates are considered normal, so when naming a rhythm, normal rates are mostly excluded from the name. Then we'll ask, is the rhythm regular? So regularity is the characteristic of the heart beating with an equivalent interval between beats. These 3 strips are all irregular rhythms, but for different reasons. Can you see how? If the rhythm is regular, it must be one of what I call the 9 basic rhythms. Otherwise, we need to look into a little further into why is it irregular. Of those 9 basic rhythms, these are the basic sinus rhythms. You have sinus bradycardia, normal sinus rhythm, and sinus tachycardia. Sinus brady is of course slow, normal sinus rhythm at the intrinsic rate of the SA node, and sinus tachycardia greater than 100. Junctional rhythm at its intrinsic rate of 40 to 60, accelerated because it's faster than the intrinsic rate, and tachycardia because it's greater than 100. Idioventricular is the intrinsic rate of the ventricles. Idioventricular meaning somewhere in the ventricles, we don't know. And the accelerated ventricular, faster than the intrinsic rate, and then ventricular tachycardia at greater than 100 again. These first 2 dysrhythmias are irregular rhythms. Premature beats is a reason for one. So you can have a normal rhythm, or maybe even normal sinus rhythm, but you have a beat that's earlier than it should be, and then if you marched it out, the QRSs on the normal parts of the EKG are going to be evenly spaced apart, and then you just have this one early beat. We name these by looking at where the pacemaker is for that premature beat. If it's an upright P wave, it's a PAC, or premature atrial contraction. If it's an upside down or absent P wave, it's a PJC. And then if it's got a wide QRS, it's a PVC. We name these just by saying like normal sinus rhythm with PACs, or normal sinus rhythm with multifocal PVCs. And these multifocal PVCs can happen if you've got multiple myocytes in the ventricles that are irritated. You would say multifocal PVCs and you would notice that it's a multifocal PVC because those 2 different PVCs are going to have different shapes. With the sinus dysrhythmia, however, it's going to be the normal QRST pattern that you see in normal sinus rhythm, but it's just irregular. So that we just call that sinus dysrhythmia. It's typically due to sick sinus syndrome. Then the last one here is a SVT, which SVT is a rhythm that fires at greater than 150 and there's no discernible P waves. It can happen that you have a rate that's really fast that's not SVT, and we find out when we try to slow it down. But for the most part, when you look at it, if you can't see P waves, it's greater than 150, it's probably SVT. This is atrial fibrillation. Atrial fibrillation in nursing school is frequently taught by looking at this baseline and seeing that the baseline is very jagged in appearance. But it's a really weak method of diagnosing this dysrhythmia because simple movement artifact can cause this. So the best way and only way, in my opinion, to diagnose the AFib is looking for an irregular rhythm that has no P waves. If you have P waves, it's not AFib. And if it's irregularly irregular with no P waves, it certainly is AFib. A flutter is one of the few dysrhythmias that you can really notice from across the room, especially when you have these high conduction ratio. You see it on the monitor, and you know, hey, that's a flutter. You have these characteristic F waves that are all sawtooth in appearance, and then they have these QRS complexes, narrow QRS complexes. We name these by the conduction ratio. So it's like this one's 7-to-1. We have this 3-to-1 conduction and then a 2-to-1 conduction. This one's a little bit faster, but in my experience, because this 2-to-1 conduction is frequently difficult to discern from a P and T waves, I've most frequently seen these a flutter at about a rate of 150, if not exactly 150. So anytime I see 150 on the monitor or 149 just holding pretty steady, I always look a little bit closer to see, are those F waves? This is ventricular fibrillation. This is another one that you can just kind of tell what it is because it doesn't have any pattern. There's no actual waves. Um, so here you have the top one we would describe as a coarse VFib and the bottom one a fine VFib. This is polymorphic VTAC. The way that we tell this is polymorphic VTAC is, for one, it's got QRS complexes that are larger than 3 small blocks that are greater than 100, just as with VTAC. However, the difference here is that the amplitude of these QRS complexes, if you want to call them QRS, is they keep changing. And what's actually happening is the pacemaker in the ventricles is constantly moving, therefore it's firing the electrical vector in a slightly different vector. It's the electricity is moving in a slightly different direction with each beat, causing this kind of helical or double helix shape. And the final question for each rhythm is there a P wave for every QRS? We'll discuss AV blocks, which is just simply a discussion about the conduction abnormality that can occur through the AV junction. This first degree AV block just causes a slight delay in the propagation of the signal from the atria to the ventricles. So when we say, is there a P wave for every QRS, you not only need to look to see if there's a P wave and a QRS, but how long is this PRI or PR interval? If the conduction is longer than one large block or 0.2 seconds, then it's first degree AV block. Second degree AV block type 1 is the next progression in severity. Both of the second degree AV blocks are recognized by an occasional P wave with no QRS. We differentiate type 1 or Mobitz 1 by noticing that the PR interval grows with each successive beat until a QRS is completely absent. Then with the next beat, the PR interval resets. So as you can see, you have the the normal PR, normal to long PR, and then you have a little bit longer, then quite a bit longer, then no QRS, then it starts over. Narrow to normal, longer, and then it'll drop again. When we progress in severity of the block, we start to get this type 2, second degree type 2. Just with type 1, you can see that the QRS complexes march out and then drop. PR interval, P, you have a P for every QRS until this dropped one. The difference is that the PR interval is the same all the way through. Then the last block, the final heart block, and certainly the most severe, is the third degree AV block. There's really no communication between the atria and the ventricles. You have your P's that march out at their own intrinsic rate of 40 to 60, or 60 to 100, and then you in the junction, in the case of the AV junction, you have junctional waves that march out at 40 to 60. And then in the case of the ventricular third degree AV block, where the block occurs lower, then you're going to get these wide QRSs that happen at their own intrinsic rate, 20 to 40, and with the P waves underlying at 60 to 100. There's no communication here. And then last slide here, we have our artificial pacemakers. This is pretty simple to understand. You have a pacer spike. It initiates a P wave in this one, so it's an atrial pacemaker. Then you have a normal QRS T, and then a pacer spike, the P wave. The ventricular pacemaker is just going to create a ventricular beat, and then the dual chamber pacemaker is just going to stimulate both beats. Sometimes you'll have a demand pacemaker where whenever the heart is beating quickly enough, faster than the set limit, which is typically around 80, then the pacer doesn't do anything. And then there's also beats like this one where you have this is a dual chamber pacemaker. It's still the same tracing. Dual chamber pacemaker. You capture on the P wave, and then there's no capture, or what we call failure to capture, on the ventricular wave. This is not going to be effective. This is not going to create a pulse. Then, as you see, you get capture here. All they just need to do is turn up the voltage slightly on this to make sure they get capture.